Hello, well, welcome back, everyone. It's very nice to see you here this afternoon. And thank you very much for joining us for the last session of today. So this session has the broad title of Future Research. And before we start, I'd like to just thank Professor Sanders for organising what's been a really fantastic showcase. We've seen some really exciting research that's taking place in Scotland. And I think something we're going to see from our last speakers is that work led by Scottish researchers can make a big difference globally. So I really hope that it inspires you to apply for some of the funding opportunities that Sarah highlighted earlier on. So we're very fortunate to have three superb speakers from three different corners of Scotland, and they're going to be talking about three very diverse topics. Between them, they'll be covering basic science, big data research, and global health research as well. So please do submit any questions that you might have for our speakers using the question and answer box. And we've got lots of time at the end that we've built in for questions and answers. So firstly, I'd like to welcome Professor Niall Strang, and Niall is the research lead for the Vision Science Group at Glasgow Caledonian University. He trained as an optometrist in Glasgow and then underwent a PhD in myopia. He spent a bit of time in Australia, I believe, doing his postdoc, and his research interests at GCU focus on a wide range of things, actually: accommodation research, refractive error development, public health, and visual performance. And one of the projects he's currently working on is a large NIHR-funded project looking at the use of atropine to try and reduce myopia progression. But that's not what he's going to be speaking about today. He's going to be speaking to us about the SCOON project. So I won't spoil what SCOON stands for. I'll let Niall explain more about it. So we'll go straight into his presentation.
Hello, I'm Niall Strang. I'm a Professor of Vision Sciences at Glasgow Caledonian University. I'm an optometrist, and I also have an affiliation with NHS Lanarkshire. Thank you very much for inviting me to talk today. Today I'm going to talk about current GCU collaborations with ophthalmology in Scotland. Primarily I'll talk about the SCON project, which is a collaboration between University of Edinburgh and NHS Lothian and ourselves, but I'll also talk a bit about the CHAMP trial, which is collaboration with the Northern Ireland Clinical Trials Unit and NHS Lanarkshire and ourselves. I will, at the end of the talk a bit about current and potential future collaborations that we could have between optometry and ophthalmology in Scotland. So what is SCON? Well, SCON stands for Scottish Collaborative Optometry Ophthalmology Network e-Research, and it's a multidisciplinary team of researchers which includes optometrists, ophthalmologists and data scientists. We got funding, we've had funding, is initial 2-year funding, which is really for a proof of concept study. And the funding was from 5 organisations: the Chief Scientist's Office, the Royal College of Surgeons of Edinburgh, Sight Scotland, Edinburgh and Lothian Health Foundation and the R.S. MacDonald Trust. The background to the project really relates to the eye care model in Scotland, where optometrists have been capturing large numbers of retinal images on a primary care population for many years. Initially, of course, this was in the form of fundus photographs, but more recently, many optometry practices have got OCT images as well, or collecting OCT images as well. This makes for a large-scale longitudinal image resource, which is potentially representative of a primary care population. The goal of SCON is ambitious in that it's hoping to build a Scotland-wide research resource of community-acquired retinal images and try to have good, robust data linkage to routine healthcare data. And this data should be secured within the IDRIS National Safe Haven. This, of course, is quite ambitious, and as a starting point for the 2-year project, our initial aim is really just to use images to evaluate early macula change in AMD using data analytics and AI applications. Future benefits, though, if this goes to plan and we continue to develop the resource, it should provide a rich pseudo-anonymised longitudinal data set which should enable us to look at early identification of eye disease, improve clinical outcomes, and uncover novel biomarkers which are predictive of ocular and systemic diseases. We're also keen to make sure that SCOAN is a sort of community project, and we want to engage with community optometry, and we see this is vital to the success of the project, and we hope that this will aid clinical decision making and triage prioritisation for optometrists. It'll also improve their clinical outcomes as well, and hopefully provide educational resource for optometry in the future. In terms of the progress so far, the first stage was really to send a questionnaire to optometrists, and this was really to gather information about the equipment and data storage facilities that are available in the practice, and looking at how record keeping is carried out as well. We also want to gauge what support there would be for the SCOAN project as well. We got some good responses from optometry, and we got 58 optometry practices responding, and they expressed widespread support for the project, and there was a report of wide range of devices, and obviously clinical record keeping processes were all different, which again can create a bit of a challenge going forward for the SCOAN project. Following on from the optometrist questionnaire information, we developed a feasibility study at GCU Vision Centre, which really was done to explore the practicalities involved in exporting retinal images and trying to link to patient data within the clinic and then transferring that data securely. We had to go through quite comprehensive governance protocols to do this, but we did manage to export a number of retinal images and link them to personal data within the system. And we used Topcon fundus images and Topcon Triton OCT images. We used a TIFF format to avoid loss and retained image quality. And we did get the images appraised once they got to Edinburgh Imaging, and it was confirmed that they were of good quality, and they were good enough quality for carrying out AI analysis. The reason we did this at GCU was that we have a large number of the patients coming into the clinic do consent to have their data used for research purposes. But there was still challenges in that some patients hadn't pre-consented, so we couldn't use their data. And then we also had some issues from the manual extraction of the data. It was quite time consuming, and it's not something that we'd be able to do if we rolled SCOAN out to the whole, to all optometry practices in Scotland. This pilot at GCU then helped inform our application for PBPP, which is the Public Benefits and Privacy Panel. And this application would allow us to get access to healthcare data, and this data would be stored in the National Safe Haven, and it would be stored, our data would be stored in a separate repository to other healthcare data, but they could be linked to other repositories. So we applied for that over the summer, and we've got approval for our proof of concept study, and we got that just in October 2021. So we've got approval to do the proof of concept study. And then what is the proof of concept study? Well, at this stage we're rolling out the project to multiple and independent practices. And the idea there is to process images that will be pseudo-anonymised and linked to healthcare data, and really the pilot will allow us to test the feasibility of doing this in a small number of practices to start with. So basically we're linking the image quality and the healthcare data, and we're looking at the healthcare data completeness. The next steps of the SCON project are continue to work with device manufacturers, continue to work with Scottish optometrists and technical teams in the National Safe Haven to develop detailed plans for the secure extraction and transfer of the information from practices, and trying to do this in a way that isn't too time consuming. We're also doing preparatory work on them in image analysis. We're doing this using some of the data that we've collected, but also using other data sets that are already available, which tend to be within secondary care settings. And the sort of end goal of this is to widen the scope of SCON to cover all optometry practices in Scotland. The next trial I want to talk about is the CHAMP UK trial, which is an NIHR EME funded trial, which is looking at atropine and the use of low dose atropine to slow myopia progression in children. CHAMP UK is a randomised double-masked placebo-controlled trial, and it's been undertaken at a number of centres around the UK. The main centre is at Queen's University, Belfast, in conjunction with Ulster University, but Glasgow Caledonian is one of the other 4 centres, which include Aston University, Anglia Ruskin and Moorfields Eye Hospital. The chief investigator in the CHAMP UK trial is Professor Augusto Azura Blanco from Queen's University, Belfast. He's an ophthalmologist and he used to be based in Aberdeen. In terms of the Glasgow site, I am the principal investigator, and we have 2 researchers collecting most of the data, and that's Dr. Stephanie Kearney and Ms. Sumra Hussain. And we also have a medically qualified investigator as part of the team, and that's Dr. Sharir Nabili from University Hospital, Hairmyres. So the primary objective of the CHAMP trial is to evaluate the efficacy of the 0.01% atropine eye drops to reduce progression of myopia in children, and we're going to follow that for 24 months. During that time, we'll be measuring axial length, cycloplegic spherical refraction, and we also have secondary objectives to evaluate the safety and tolerability of the low concentration atropine eye drops and to determine the mechanism of action of the atropine drops. We also have some exploratory objectives, so we will look at the influence of other factors on the progression of myopia, and we'll look at things like the hours of outdoor activity, for example, the use of spectacle correction, how often is the spectacle correction used, the ethnicity of the child, and family history. The trial is aiming to recruit 289 children across the 5 sites, and the children will get drops and they'll have to take the drops once daily for 2 years. They visit the GCU centre every 6 months to get their refractive error and various other measures taken, and what we'll do with that is measure the change in the refractive error and axial length over the 2 years of the trial. The drops, the atropine drops and the placebo are collected from Hairmyres Hospital every 6 months as well. The full protocol for the CHAMP trial has been published in the British Journal of Ophthalmology, if you're interested. The trial will work on a 2-to-1 ratio of atropine to the placebo. The placebo just being sodium chloride 0.9% and benzalkonium chloride 0.01% in sterile water, and the atropine is atropine sulfate 0.01% with benzalkonium chloride 0.01 in sterile water. So both will have preservative. The inclusion criteria for the trial is 6 to 12 years of age at the time of consenting, And the myopia is, you've got to have myopia of minus 0.5 diopters or greater. That's the spherical equivalent refractive error in each eye. And the best corrected distance visual acuity of 0.2 logmar or better in each eye. The exclusion criteria for the trial is myopia of greater than or equal to minus 10 diopters in either eye, or astigmatism of greater than 2 diopters or greater in either eye. There are other exclusion criteria, including significant health problems that might compromise the ability to attend the trial. And a problem that's come up more and more is this prior or current use of atropine, potentially, or other refractive myopia control techniques, which may influence the results of the trial. In terms of progress for the trial has been running throughout the COVID-19 pandemic, so it has had there has been a number of challenges, to say the least, but we are on track to finish recruitment of participants in the next month or two. So we still have 2 years to go to follow up the final participants, at what point we can start analysing the data. In terms of other current and future collaborations with ophthalmology, the GCU has close links with NHS Lanarkshire now, and we have a joint PhD studentship between ophthalmology and vision sciences, which is investigating post-cataract patient visual outcomes. We also have some good student project collaborations between ourselves and St Andrews University, and these have progressed now to Visual Research Trust summer scholarships as well. We've recently had one ophthalmologist going through the PhD by publication route at GCU, and this route is something that we offer and maybe something to consider for ophthalmologists who have published a number of papers. In terms of public health, we have also collaborated with ophthalmology on developing a number of public health papers. The data used in the papers generally relates to the eye care model in Scotland, and of course it's quite a rich source of data, and it's something that could probably be mined even more. And we do at GCU have good quantitative and qualitative research expertise, both within vision sciences and within other research groups within the university. So we've got other health researchers within the Research Centre for Health and the UNIS Centre at GCU. Thank you for listening today, and feel free to contact me on the email address below. Thanks.
Great. Well, thank you very much, Neil. We hope to ask you some questions about your work later, but there's a great range of projects that you've been leading at GCU, and I think really nicely highlighted the potential for better collaboration between ophthalmology and optometry in terms of research in Scotland, and the unique resources that we have here for that. So thank you again, and please, just a reminder, please do submit any questions that you might have for Neil or any of our other speakers. So we'll move on to our next speaker. So I'm very pleased to welcome one of my colleagues, Dr. Manjit Mehat. Manjit is a vitreoretinal surgeon, and he trained at Moorfields and completed a PhD at UCL, and his PhD was some really, really interesting work where he was involved in retinal gene therapy trials. And Manjit was actually a senior investigator on the world's first gene therapy trial, which was published in the New England Journal of Medicine, and was lead author on the first European trial for stem cell transplantation for inherited macular degeneration. So he's really been at the cutting edge with his research to date, and he's continuing that in Edinburgh. So I'll hand over to Manjit.
Thank you for this invitation to the Scottish National Research Day. My name is Manjit Mehat, and I'm currently a consultant vitreoretinal surgeon at the Princess Alexandra Eye Pavilion. Over the next 25 minutes, I hope to talk about gene and cell therapy approaches to treat retinal disease and why they're important So, firstly, why do we really bother investing so much time, energy, and kind of resources in gene and cell therapy? Well, the simple answer is, disease, as far as the eye is concerned, has really changed over the last 20 years. And these graphs quite beautifully illustrate that. So we look at our young working population. The commonest cause of irreversible blindness and kind of registration for sight impairment is inherited retinal disease. So 20% of these patients have genetic conditions causing blindness. And this is a marked change from, say, 50 years ago, when conditions such as diabetic retinopathy were the leading cause of blindness in this in this population. And this in many ways is a reflection of diabetic retinopathy screening service that we currently run. And equally, if we look at the as a population as a whole, and so taking more of the elderly population who become registered with severe sight impairment, it's not surprising that these patients largely suffer from degenerative macular disease, largely dry AMD. And for both inherited retinopathies and dry AMD, there is really no silver bullet. These patients go blind, and there's very little we can offer as ophthalmologists for their in order to kind of regain sight. And so it's because of this, people are looking towards gene and cell therapies to address this kind of significant burden of disease. In many ways, as ophthalmologists, we're extremely lucky, as the eye often offers the perfect organ system for translational research. The eye can be easily accessed in order to deliver cell and gene therapy. The laminar structure within the eye means that relatively small volumes can be delivered within confined spaces. The retina also has a stable cell population, which is particularly important when delivering gene therapy, as it means we don't have to keep re-delivering the vectors in order to produce our treatment effect. The ability for the eye to have elicit an immune-privileged immune response is also important, particularly when it comes to delivering cell therapies, as delivering these in other organ systems may have serious consequences for immunosuppression. We also have the contralateral eye, which acts as an excellent control when designing studies. And the eye, being a non-vital organ, is also very favourable, particularly in the first in human trials of gene and cell therapy. All in all these make the eye the first choice for translational research. On the right side of the slide, what you'll see here is a video of a subretinal injection being performed. Here, a 41 gauge needle goes through produce a retinotomy, and then fluid just injected underneath to create a bleb. And then the syringe is then reloaded with the cell therapy, which in this case is RPE cells, which are derived from human embryonic stem cells. And the needle goes to the same retinotomy site to inject the RPE cells. You can see the central macula has significant dystrophy, and this is a patient with Stargardt's macular dystrophy. And the RPE cells are delivered just below the inferior arcade there. And here you can see the bleb just kind of fashioned where the cells are delivered. And this kind of gives you an idea of the kind of key kind of characteristics of the eye which allow such procedures to be undertaken relatively effortlessly. And it's not only the delivery of these cell therapies which is important, we also have in vivo imaging such as OCT, which allows us to see engraftment cells and analyze structure post-injection of either gene therapy or cell-based therapy. Using more novel approaches such as adaptive optics, SLO, we're able to characterize single photoreceptors and determine the effect that these novel therapies have. We can also use fundus autofluorescence determine the effects that these therapies may have on disease progression. And in terms of retinal function, we can measure retinal sensitivity using microperimetry and provide a topographic map of changes within the sensitivity across regions of treated and untreated retina. The two main techniques used for regenerative medicine is both gene therapy and cell-based therapy, and the two forms differ considerably. If we think about gene therapy in its most simplistic aspects, what we're doing is trying to introduce a normal copy of the gene into a patient who has a mutant or defective copy of the gene. And the way in which this is done is using adenoviruses. Adenoviruses are common viruses which cause the common cough and cold every winter. And what scientists have very successfully been able to do is to take the DNA of the adenovirus, strip out all the pathogenic elements of the DNA, and incorporate what we call the therapeutic gene. And this is a gene of interest, which will ideally deliver the normal gene into patients with a defective form of the gene. Naturally, there are limitations with AAV vectors, and one of the most significant limitations is what we call cargoing capacity. So the vectors can only really carry small genes, and as a result, the first gene therapy which has really been trialled is for LCA, Leber's congenital amaurosis. Although this represents a relatively small percentage of all inherited retinal diseases, the reason why this has kind of emerged as our primary target for gene therapy is the fact that the RPE65 gene is relatively small. The disease progression is also relatively slow, and therefore gives a opportunity or a therapeutic window in order to do so. And so with this in mind, it's not surprising that the first publications for successful gene therapy all targeted Leber's congenital amaurosis. However, what was probably more interesting was what they demonstrated, and what's clear from certainly two of the groups who undertook these early clinical trials and gene therapy was that certainly in patients who respond to the treatment, they do so very well, and certainly by the first year, retinal sensitivity increases significantly in the treated eyes. However, what is of interest is that in two of the three groups, they demonstrated this clear loss in retinal sensitivity following the initial gain. And so there is this big question being asked in terms of what is really the longevity of gene therapy, and whether the vector is able to maintain expression of the normal gene copy. However, despite this, one of the three groups was clearly able to demonstrate that although gene therapy may not improve retinal function as measured by microperimetry and best corrected visual acuity, what it did seem to do is to improve patients' ability to navigate. And so this led to the Jean Bennett group undertaking a phase 3 clinical trial, which is a multi-centered trial involving bilateral injections of RPE65 vector. And what they demonstrated in this article kind of shown here was that patients showed a significant and sustained long-term improvement in their navigational vision. And from this study in 2017, they then received FDA approval for Luxturna, also known as Vortigene Naparovec, and this then led to both NICE and SMC approval for LCA for Leber's congenital amaurosis patients. What's very important to mention is the cost of treatment. So a single vial of treatment currently costs somewhere in the range of £600,000. However, I do know the NHS have negotiated a discount for this, but it's a huge kind of cost implication on this. And studies also suggested even though gene therapy may, in LCA, may seem to improve mobility, the degeneration, certainly in patients, does continue even though there is an improvement in function. So coming around to what kind of local things are we doing, in particular Rolly, Mughal, myself, we're currently trying to run a commercially sponsored gene therapy trial at the Eye Pavilion, and this is for X-linked RP. And so this is, like I said, it's a commercially sponsored trial using AAV2 vector targeting the RPGR gene mutation. And what we're looking for is patients with X-linked RP with confirmed mutation of the RPGR gene. And if you have any of these patients who have relatively preserved retinal function, then please do get in contact with us. The trial involves bilateral injections, with the second eye being treated 7 to 21 days, and its primary outcomes are safety and efficacy. And efficacy will be measuring best corrected visual acuity, mobility, octopus perimetry, including microperimetry, together with patient-reported outcome measures. So if you do have any of these patients and they'd be interested to explore gene therapy as part of a clinical trial, then please do let us know. So probably the next question I want to probably try to touch on is, where's the role for cell therapy in all of this? And cell therapy really tries to address the more elderly population, these patients with age-related macular degeneration, particularly due to the fact that AMD is a very kind of complex disease. It has this complex interaction between both genetic and environmental factors, with age probably being the most important of these. And genome-wide studies have suggested that there is really no kind of single cause for AMD, and it really represents a complex interplay between complement pathways, lipid metabolism, and oxidative stresses. And so, it's difficult to really address this condition through gene therapy because there are so many kind of unknowns here. And so, for conditions such as this, what's envisaged is using cell therapies. And there's really two types of approaches when it comes to cell therapy. One's protective effect, and the other one's replacement. And the protective effect involves introducing stem cell-like cells which can secrete trophic factors which may support the longevity of these degenerative cells. And examples of such include kind of bone marrow, umbilical cord tissue, and fetal retinal progenitor cells. And this is a relatively kind of simple approach to cell therapy. More kind of higher order approaches is recapitulating the retinal environment in order to kind of sustain function. So you're trying to reintroduce RPE cells, photoreceptor cells, ganglion cells, in order to recover the lost function. And this is really a real big ask, because what you're trying to undertake here is not only are you trying to make the cells survive in a native environment, you're asking for them to kind of engraft and integrate within the kind of neural circuitry. And if you look at all the cell types that you may want to target, you consider ganglion cells, photoreceptors, and RPE. And of these, RPs currently the kind of building block or the starting point for cell therapy. And there's a number of reasons for this. First and foremost, before we can even think of introducing photoreceptors, what you need are healthy RPE cells in order to sustain and support the overlying photoreceptors. The RPE also represents a simple monolayer, which doesn't require any neural integration. Previous clinical studies have also demonstrated proof of principle using autologous donor RP from peripheral retina in patients with AMD. And so the hope would be that this kind of lack of donor tissue may be fulfilled using stem cell derived RPE. And that really kind of led to the first kind of in-human clinical trial of embryonic stem cell derived RP, and this is something that I kind of worked on in my PhD, and was the first trial in Europe for transplanting RP, which are derived from embryonic stem cells. And this is for a condition called Stargardt's macular degeneration. So Stargardt's macular degeneration is the commonest cause of inherited macular degeneration in children, and it has an orphan disease status as it affects about 1 in 10,000 births. It's an autosomal recessive disorder which is caused by a mutation on the ABCA4 gene. And as I said, this gene is a relatively large gene, and so it's not really amenable to AAV gene therapy. The gene codes for an ATP binding cassette transporter, and the current working hypothesis is that abnormalities in the gene cause the accumulation of toxic vitamin A derivative within the RPE, and it's usually loss of the RPE, which then has a adverse effect on the overlying photoreceptors, which causes degeneration. And currently there is no treatment for this condition. And so the study rationale for this was that when the provision of healthy RP cells could help to sustain photoreceptors, and in doing so potentially rescue and delay visual loss. The primary objectives was to kind of assess safety of subretinal transplantation, evaluate survival of the RP cells which were transplanted, and somehow to kind of determine the kind of numbers and potential endpoints for further studies. And this was a kind of early phase clinical trial, open labelled, with a sequential enrolment with a dose escalation in each cohort. All patients underwent immunosuppression. And in order to be recruited to the study, you had to have a Group 3 Stargardt's macular degeneration, which is the most advanced form, where you have both complete loss of rod and cone ERGs. Procedures performed using 20 gauge vitrectomy with subretinal injection with 41 gauge cannula. And an important question for us, well, where do you inject the cells? These patients, because of the advanced nature, had no retinal activity centrally, and so they relied on parafoveal fixation. And if you just look on this microperimetry, you can see just as you move away from the central macula anteriorly, the sensitivity within the retina starts to increase. And we define this as this kind of transitional zone, and the idea was to transplant cells within this transitional zone. And in terms of safety, we reported no SAEs, and there were a few adverse events. These were kind of limited to hemorrhage, epiretinal membrane, hemorrhages which spontaneously resolved, and cataracts. So what do we see in terms of structure post-transplantation? Well, these are montage colour-funded photographs of patients being injected with 50,000 cells and 200,000 cells. And what's interesting is the dotted line, the circular dotted line, represents the area of what we call bleb formation, where the cells were engrafted, and the green dots identify the area of the retinotomy. What you can see illustrated quite nicely in these pictures is that the area of the bleb formation started to become pigmented, and in many ways this is kind of almost hyperpigmentation, and this started around early month 1, 2, 3, and then kind of progressed all the way to month 12. And if we plot the change in pigmentation, you can see this kind of early phase 0 to 3 months where there's this sharp increase in pigmentation, and it seems to kind of stable off, and it's maintained for month 12 post-transplantation. And we follow these patients up for up to 5 years, and you can see that the pigmentation remains up to year 4 and even 5. But what's interesting is that the density of the pigmentation does appear to reduce. Functionally, what did we note? It's not surprising that none of these patients had any change in vision, given the fact that these had the most severe types of Stargardt's macular degeneration, i.e. Group 4, where there was complete exhaustion of all rod and cone ERGs. We did assess changes in microperimetry, and equally we saw no statistically significant change in microperimetry over the area of transplantation. So in conclusion, we conclude that subretinal transplantation of human embryonic stem cell derived RP appears to be safe. It's well tolerated. There's dose-related increase in subretinal pigmentation. We didn't demonstrate any evidence of any efficacy in terms of change in retinal function, and whether these cell transplantations have a more long-term protective effect remains yet to be determined. So clearly, in terms of a kind of proof of principle, transplanting RP cells seems to be functionally possible. But where are we with the photoreceptors? The real game changer for stem cell derived photoreceptor generation really came from a paper from a Japanese group led by Singh in 2011. What they were able to generate, or were able to kind of report, was this what's described as almost an autonomous formation of optic cup structures within 3D cultures of mouse embryonic stem cells. And as this kind of as the image just in the top right demonstrates, if you take a free-floating ball of embryonic stem cells with conditioned media, after almost day 3, 4, 5, you start to have this protrusion of these optic cups, which then undergo a process of invagination. And when these optic cups were sectioned and stained, it showed early markers for retinal progenitor cells. And the group were later able to kind of demonstrate similar results using human embryonic stem cells, and also other groups have shown using iPS cells. And going forward, what collectively the scientific community have shown is that you're able to grow these photoreceptors from embryonic stem cells in the lab and transplant them to models of retinal disease, and these might be kind of mouse and rat models of retinal disease, and show rescue. The only kind of slight caveat with all this research recently has been a paper which has shown that actually this may not be completely true transplantation. There may be a kind of process of material transfer, which we can save for another discussion. But how are we using, or how am I using some of this kind of acquired knowledge to kind of develop local expertise? Well, thankfully, due to my kind of NRS clinical lectureship, and coupled with the University of Edinburgh's kind of established track record on investigating inflammation of scar tissue, one of the key areas I'm interested in is to try to optimize integration of cells, particularly in the degenerative environments. One of the kind of key challenges moving forward is how do we transplant cells such as RP and photoreceptor cells into patients who have quite advanced degeneration, and how do we modulate the transplant niche in order to optimize both engraftment and survival. And one of the ways in which as a VR surgeon you can really learn from is really looking at retinal detachment. So we know that patients who detach often develop PVR changes, and an interesting way in order to analyze changes taking place at the retinal point in terms of degenerative changes is to analyze PVR tissue and see at a kind of molecular level what the cell signaling that triggers scar tissue formation, how may we kind of modulate these changes in order to improve transplant efficiency. So finally, I'd like to kind of thank some great mentors. First and foremost, Professor Jim Bainbridge and Robin Ali, who really kind of set the path for me in terms of developing and acquiring a lot of these kind of clinical research skills that I have. I was very fortunate to be working in their lab at a time where so many kind of interesting things were happening in the field of regenerative medicine involving the eye, and I'm always kind of eternally grateful to both of them. And secondly, a chap who's Singh, who has a very kind of rich history and also kind of works at the Eye Pavilion. I found out about something here when I was probably in ST1 in ophthalmology, and I read this fantastic article called Adventures in Three Worlds. And any kind of junior trainee kind of listening in on this presentation, I would kind of thoroughly recommend that they try and find this kind of article written by him called Adventures in Three Worlds. It's a very kind of inspiring article of his journey through the world of ophthalmology. And many times when you fall short of your luck in research, just kind of reading this article will often certainly kind of help in kind of lifting your spirits. And I think it's a great read. Thank you very much for your time in listening to this presentation. I'm happy to take questions at the end. Thank you.
Great. Well, thank you very much, Manjit. That was a fascinating insight into really translational research. So I've got quite a few questions for you, actually, mainly because I know nothing about this area. So some of them will be very basic, but we'll save them for the end. It was also very interesting when you said that VR surgeons are interested in bleb formation. So it's not just glaucoma specialists anymore that want nice blebs. Our last speaker, I'd like to introduce Dr. Andrew Blaikie, who I think everybody will already know, because Andrew is a senior lecturer in the Infection and Global Health Division at University of St Andrews. And he was most well known for me, obviously, because of his work with the fantastic ArcLight device, but he is involved in so much more than that. He's very active in developing education tools for healthcare workers globally, and there's several other areas of his work which I think he'll talk about. He'll be speaking to us about frugal ophthalmology, which probably is relevant not just in low income and developing countries. So, Andrew, over to you.
Hello, my name is Andrew Blaikie. I'm a consultant ophthalmologist in NHS Fife and senior lecturer at the University of St Andrews. Thank you for inviting me to speak this afternoon about the ArcLight project. The motivation for the ArcLight project is based on the inverse care law, where the greatest burden of disease is sadly found in the regions of the world with the least access to healthcare. In part, this is due to medical diagnostic devices being expensive to buy, as well as hard to maintain in working order. In low-resource regions, the continual need for hard-to-find and impractically expensive consumables such as batteries and bulbs often means that well-minded donations of equipment end up in the bottom drawer, gathering dust after a few months of use. My colleague, William J. Williams, an optometrist and lecturer in the School of Medicine at the University of St Andrews, has applied his engineering and design skills to address the limitations of current expensive traditional eye and ear diagnostic tools, considering the barriers and solutions. The following video describes the ArcLight in 60 seconds. Hello, my name is Dr. Andrew Blaikie. I'm an ophthalmologist with the University of St Andrews, and this is the ArcLight device. The ArcLight is a direct ophthalmoscope as well as an anterior segment loop for examining both the back of the eyes and the front of the eyes. It also can examine the ears as an otoscope. The unique features of the ArcLight device is that it has an LED as its illuminant, and this is charged both by a solar panel on the side as well as a micro USB connection. The limitations of the traditional direct ophthalmoscope includes the initial high cost as well as the need for continued supply of consumables such as batteries and bulbs, whereas the ArcLight is a low-cost device to buy and doesn't require a supply of batteries and bulbs. The majority of people with visual impairment in the world unfortunately live where the access to diagnostic devices is least. If we can get the ArcLight device into the hands of healthcare workers in these lower resource settings, the burden of disability due to hearing impairment and visual impairment will be reduced. A direct ophthalmoscope requires the examiner's view to be aligned to a light source. Traditional direct ophthalmoscopes use a filament bulb, projecting light from below in the handpiece onto a mirror, which the examiner then looks over along the line of sight. The ArcLight device uses a different approach, exploiting the small size of an LED and placing it directly below the sight hole of the examiner. This offers several advantages: reduced cost, simplifying the engineering, allowing the device to be smaller. The LED can be powered by a small lithium battery, and this battery can be charged by a solar panel housed on the surface. The device has gradually evolved over the past 10 years to the current Mark IV arc light. Despite its small size, simplified engineering and unorthodox appearance, an evidence base for the device has also gradually developed, supporting its role as a replacement for much more expensive traditional tools. One of the earlier studies evaluating the arc light was performed in Malawi and published in BMJ Innovations. This demonstrated the device in the hands of mid-level eye care workers to be as effective as traditional devices in identifying posterior segment eye signs such as diabetic retinopathy and glaucoma. This study was followed up by demonstrating equivalence to a traditional direct ophthalmoscope in identifying red reflex abnormalities, such as cataract retinoblastoma and coloboma. The arc light device comes with a range of additional tools in a small packet. As well as the arc light device and an instruction sheet, there are two speculae to turn the device into an otoscope: a near visual acuity and matching card, a clip to attach the device to the camera of a mobile phone, a USB lead to charge if the sun don't shine, a 3-metre distance visual acuity chart, and a lanyard. As just explained, as well as being a direct ophthalmoscope, by attaching a speculum the device becomes an otoscope. A comparative study performed at Niall Hospital in Dundee demonstrated the arc light to be as effective as a traditional, more expensive otoscope at identifying clinical signs in simulated ears. A further comparative study was then performed in Malawi amongst a range of ear healthcare workers, and again the arc light performed as well as a traditional device. Distributing devices does not necessarily mean they're going to be used effectively. As a consequence, we have developed a number of simple simulation tools that mimic anterior and posterior segment disease. These can then be used to train, then assess participants at workshops in a fun and engaging way. These tools have been evaluated and shown to be much more realistic simulation than vastly more expensive electronic devices that are typically found in medical schools and training centres in the UK. They also have a major role to play in remote hybrid teaching during the COVID era, with a short report recently published in Eye describing this. This video demonstrates the fundal reflex abnormalities that can be mimicked using the SimEyes. This is key to training and importantly assessing the competency of community healthcare workers in low-resource countries. As a consequence of the arc light being low cost and easy to use, newborn fundal reflex examinations are now possible in this setting, where in the past they were simply not performed, with children presenting late with untreatable disease. Colleagues in Tanzania have gone on to perform a large-scale community study amongst primary healthcare nurses and shown that the arc light can be used effectively to screen babies and young children for medial opacity and retinoblastoma. This study has convinced a number of NGOs to develop large-scale screening programs in sub-Saharan Africa and Asia using the arc light device and the simulation training tools. As well as performing the fundal reflex for identifying gross medial opacity such as cataract and retinoblastoma, a recent study from India showed that the Bruckner reflex using the arc light can be interpreted with high sensitivity and specificity for squint and refractive error, using the results of a full paediatric eye clinic workup as the gold standard. These are the types of appearances that can be gained with the arc light, allowing all amblyogenic risk factors to be easily identified with a quick, non-touch, arm's-length examination. These images and videos can be acquired for teaching, second opinion and telemedicine purposes by attaching the arc light to the camera of a phone. This has transformed how I teach the fundal reflex, direct ophthalmoscopy and otoscopy in the medical school and beyond. On the right is the appearance of a real direct ophthalmoscopy examination of a medical student. On the left is the appearance of a normal simi. Simis have a wide range of different pathologies that can be printed out using a domestic printer and placed in the simi. This can be used for direct as well as indirect ophthalmoscopy and on the slit lamp. Colleagues in the ophthalmology department at Nine Wells Hospital in Dundee have compared the ArcLight to a traditional device as a tool to teach medical students how to perform direct ophthalmoscopy. The students performed better with the ArcLight and preferred using it compared to a traditional device. Professor Moen's team from Lahore in Pakistan have performed a similar study, but amongst non-ophthalmology residents, finding similar positive results. They concluded that in addition to being cost-effective and compact, the ArcLight is easier to use with a shorter learning curve for beginners. It's also better tolerated by patients, providing more comfort during the examination. The team in Pakistan have also performed a comparative study identifying and classifying diabetic retinopathy in the community, showing that the ArcLight device is again as effective as traditional, more expensive tools. In view of the clear benefits of the ArcLight as a tool to teach both beginners and non-eye care healthcare workers, we have developed online instructional videos that support the implementation of the device in both high and low resource settings. These are available on the ArcLight project website and our YouTube channel. The videos cover how to assess visual acuity, examine the front of the eye using the anterior segment loop in a systematic manner, labelling and explaining the different parts of the eye. Then how to identify areas of epithelial loss and infection using the blue light. The steps on how to assess the fundal reflex of an adult and a baby are clearly explained, and how best to set up the ArcLight to see these different pathologies. Video and images of normal and abnormal clinical signs are shown and explained. Then finally, the steps on how to perform direct ophthalmoscopy most effectively are illustrated, highlighting the features of a normal, healthy optic nerve. We have consequently gone on to establish an ArcLight interprofessional education package, which we've evaluated amongst nurses, clinical officers and medical students in Rwanda. This demonstrates that primary eye care can be effectively taught in an interdisciplinary way to strengthen existing blindness prevention programmes. The 3-metre cloth logmar distance acuity chart that comes in the ArcLight package has also recently been assessed by the Glasgow Caledonian School of Optometry and compared to the EDTRS chart with excellent correlation found with the gold standard. We aim to publish this in the near future, as well as perform an evaluation with colleagues in Malawi in 2022. As a consequence of the developing evidence base and supporting simulation tools and training content, the device has been adopted by a wide range of NGOs and training institutions throughout the world, with over 33,000 devices now out there being used on a daily basis. The ability to attach the device to the camera of a mobile phone opens up the possibility of using the ArcLight as a digital device of record and applying algorithms to images and video to automatically diagnose eye disease. We have worked on some algorithms and have been able to segment the optic nerve to identify the cup and the rim and compare to an expert's subjective opinion with reasonable accuracy, a work in progress. In addition, we have attempted to stitch individual frames from retinal video into slightly larger montages as a means to widen the field of view, overcoming the innately narrow view that direct ophthalmoscopy gives. To expand the functionality of the ArcLight, we've engineered a tonometer that attaches to the loop end of the device. This uses brass weights that apply force to the cornea with the patient in the supine position. We're hoping to start evaluation of this in 2022. In addition to a direct ophthalmoscope, we have developed a binocular indirect ophthalmoscope using the same frugal engineering approach to the ArcLight, being solar powered, using LEDs, simplifying the optics and making it easier to use. A comparative study with a more expensive traditional device has recently been accepted for publication in Eye. This study demonstrated the new indirect to be equivalent to vastly more expensive indirects. As I hope can be seen, the ArcLight project is gradually moving towards creating a comprehensive package to equip and train primary, mid and tertiary level healthcare workers in all economic regions of the world to reduce needless blindness. Many thanks for giving me the opportunity to give an overview of the research associated with the ArcLight project.
Great. Well, thank you very much, Andrew. That was fascinating and incredible to see the global reach that the ArcLight device has had. I really liked that image, though, the first incarnation of it held together with masking tape. It's interesting to see how it developed over those 10 years. So we've heard from our three speakers, and I'm sure you enjoyed hearing from them. I'd like to welcome all three to join me. So Niall, Andrew and Manjit, if you could perhaps turn on your cameras and unmute yourselves, and we can have a discussion. So great, nice to see you all live. Hi. I'll start off. If you have any, also Niall, Manjit, Andrew, if you have any questions for each other as well, please just go ahead. It's a discussion, not just me asking questions. But there's a question from Robert Murray. First of all, to you, Niall, and he asks. He says there's been many studies on the use of atropine for limiting progression of myopia in children, and he wonders what's new about this study.
Okay, thanks. Yeah, I think that most of the trials in atropine have been done in the Far East, sort of China and Singapore. And so part of the idea was to get some understanding of how effective atropine would be in a Caucasian population. It's not the full goal of the study. There is we accept all ethnicities, but I think that's certainly part of the driver for this.
Great, thank you. I hope that answers your question, Robert. Could I ask you as well a question, Niall? I wondered how receptive you found the optometrists for sharing data in terms of the Scoon project, because I imagine that could be a potential barrier, that particularly if patients haven't given necessary specific consent for sharing their data. And have you found that there's a difference between sort of independent optometrists and multiples?
Yeah, I think it's been a challenge. I think the questionnaire was. We sent the questionnaire to sort of every optometrist, and you got responses from a limited number, you'd have to say. But again, this was during a very busy time for optometry, and we got what we got basically back. But I think overall, within the sort of wider optometry community, there is quite widespread support, and they can see the potential in the project going forward. And I think it's important for us to keep talking about how we want to make sure that this is going to be beneficial for everyone. It's not about us sort of squirreling away everyone else's data and using it to our own for our own good, and then keeping it away from everyone else. This is about hopefully, the way I see it, is about it's a whole sort of Scotland-wide development, if you like, and it should be beneficial to everyone. So independents, we're talking to independents and multiples, and they're all very keen. There's issues, and it's very much a challenging question, trying to get everything in place. And I don't want to bore you with all the real details. Hopefully even the talk gives you an idea of the different stages we've got to go through to essentially do something which you would imagine when you think of this to start with is essentially quite straightforward and just getting an image from someone's computer, but it doesn't quite work like that. And so I think overall, I would say optometrists are very happy to be involved. They want to be involved. The only caveat I would say on that is they don't want to have to spend a lot of their clinical time doing it. And I think that's the challenge for us, to make sure it's really easy for optometrists to do. And that's both multiples and independents. And if it is, I think there'll be
I think they would be very supportive of it.
Great. I think, as far as I'm aware, I mean, there are other big sort of data groups, like Moorfields have been looking at their data from virtual clinics, and but I'm not really aware of any big data sets from primary care. So perhaps this will be a unique, at least unique in the UK, having that primary care data.
I think this will be unique in the world in that respect as well. I think the Scottish model of eye care helps us to do that, and I don't think there's anywhere else. Nearly all the other data sets are secondary care data sets.
And that I suppose, if you're looking at artificial intelligence, and if people are developing AI algorithms and they've developed them using hospital data, then it might not be generalizable to primary care data. So it could be a really useful test bed. So. Exactly,
and that could make a huge difference to levels of sensitivity and specificity.
Yeah, no, it's really good work. And you mentioned that you want it to benefit as many people as possible. Will researchers be able to access the data? Once it's there in a safe haven, could somebody come along and apply to use the data, like a biobank data, perhaps?
Yeah, I think we're quite far away from that yet, but I think we want to start using the data to a certain extent, but I can see that down the line. I think there is potential for that, yeah.
That's great, super. Please do submit any questions for people that are listening as well. So perhaps, could I ask you some questions, Manjit, now? That'd be all right. Manjit, really, really interesting work. Something you mentioned is the environment in the eye. Whether it's an environment that sort of supports sort of cell survival, and I just wondered, something that really would change the environment in the eye is vitrectomy. I imagine that can do. I don't know whether that has a positive or negative effect, but I wonder, do you think it has an effect on the environment, on cell survival, for instance? And if it does, how do you actually control for that? Because if you're doing a study where you're doing a vitrectomy and injecting something subretinally, I presume you need to do a vitrectomy to do that. How do you sort of tease out? I presume you don't have a control group where you just do a vitrectomy and inject placebo. I don't know.
Yeah, so no, that's a very interesting question. I'd probably say so most of the cell and gene therapy is injected within the kind of subretinal space, and there is really no, due to cell-to-cell adhesion and various kind of barriers within the eye, there is no kind of direct interaction with the intravitreal cavity. And equally, patients undergo vitrectomy for a whole variety of different medical conditions, ERMs, ILMs, macular holes, and so forth. And so you could argue that you have a control population in that aspect. But you're quite right. For most of the current work, which involves subretinal transplantation, either being a vector or cell, we have to do a vitrectomy. However, there are more newer surgical approaches. And for example, using the suprachoroidal space is one avenue. And the reason why these approaches are certainly being looked into is many people do have concerns that when you have to inject within the subretinal space, you're in essence creating a localized retinal detachment. And we know that when the detachment's caused, you can often misalign the photoreceptors, and therefore that can be a variable in terms of its overall outcome. And that's certainly been interesting in the gene therapy trial that we conducted with RP65, where post retinal detachment, we did see a thinning of the central kind of foveal complex. So alternative approaches are being carried out. As far as does the vitrectomy interfere with either cell survival, integration, or expression of the vector, not convinced there.
Do we need a vitreous once the eye's developed?
Most VR surgeons will argue no. Apart from removing the vitreous content does accelerate cataract formation, but that's unfortunately one of those things we just accept.
So it's a bit like the appendix of the eye, I suppose.
Yes.
And are there any other methods of drug delivery you think might be feasible, apart from sort of directly injecting under the retina or the suprachoroidal approach?
So right now, in order to administer the type of doses that we need to do, those are kind of key approaches. Currently, that I'm sure that in the future will change. However, apart from, there is currently no clinical trial that I'm aware of that uses an alternative method to those.
Mm-hmm. Okay, and you mentioned there are quite a few outcome measures that you take, both structural and functional, and patient-reported outcomes as well in the studies. And do you think that some of those are not routinely collected in clinical practice? Do you think any of those could be useful in clinical practice in the future? Do you think some of those outcomes might translate back into clinics?
That's a very valid point. One of the techniques that I've certainly kind of used in my clinical practice is microperimetry. I think this is a tool which is quite widely used within clinical trials and provides a almost kind of perfect topographic map of retinal sensitivity. And one thing that we're very keen on in our clinics is trying to work out disease progression. And what we want to do is try and work out the population of patients that we can identify within the people that we treat, who needs more aggressive management and who we can probably sit back, have 6-monthly reviews, and those patients where you really want to bring them back every couple of weeks just to monitor how their treatment's going. And microperimetry is an excellent tool where we can map topographically retinal sensitivity over time and determine rates of change within sensitivity. And I think that is something which I've certainly at Morphos we use quite a lot with certainly our macular disease patients. Yeah.
Mm-hmm. So you're not just interested in blebs, you're interested in perimetry.
Absolutely.
Glaucoma specialist. Good. And lastly, I just had a question also about the potential perhaps for sort of unregulated cell proliferation if you're using sort of trophic factors, or is there concern, or are there any reports that it could be harmful cell proliferation?
It's a great question. So when we conducted our first RP stem cell trial, one of the concerns, one of the things that we actually consented patients for, was the fact that these cells that we've kind of grown in the laboratory, which we've differentiated from embryonic stem cells, you may within say 1,000 cells you place in, there could be an escape of a cell which is undifferentiated, and once it enters your subretinal space, it will proliferate, and you've got a tumor in the back of the eye. And these are always risks that we kind of carry when doing this type of study design. Although reassuringly, there are a whole bunch of safety stages at which we differentiate and divide these cells in order to identify this. Other interesting things are, for example, a Japanese group were able to take skin samples and to convert them to iPS cells, which are going to reprogram adult cells from our skin and turn them into embryonic stem cells using manipulation of their kind of genetic expression. And that trial was actually halted midway due to the fact that as part of their safety checks, they were able to identify abnormalities in the karyotypes of these cells. So, this is, I think, one of the challenges that you have. You're trying to introduce these very novel therapies into clinical practice as part of the kind of translational aspect. And these are serious risks that you have to try and think about and account for. And that's why in many ways we are eternally grateful for those participants who engage on these clinical trials, because they are in many ways putting themselves at the bequest of clinical researchers when engaging with these type of therapies. And it will probably be some years before we kind of really get everything to a level where we can make a real big difference for our patient group.
Great. Well, thank you very much. Super. So, Andrew, could I ask you a few questions as well? We've had a couple of questions coming from people tuned in at home. So we had a question from Nikki Hall, and she asks, how far along is the development of the ArcLight indirect ophthalmoscope, and when will it be available? You have your first customer.
Yeah, sure. So all the engineering for the indirect's done, and we've evolved it from the Mark 1 to the Mark 2 after doing a pilot study. So the optics are all sorted. The next step simply is to get the light source certified. make sure it's a class 1 device, and then it's good to go. So I think for the last 18 months I've been saying 4 months time, and I'm going to say 4 months time again. Sorry.
Great. I mean, for anyone who hasn't bought their own arc light, I would definitely recommend it. Do buy your own. I mean, a thought that I had was that you showed how it can be tremendous value in low middle income countries, but I thought I had also is that it could increase access to ophthalmoscopy in the UK, and particularly amongst medical students, and I just wondered, when we start medical school, we buy a stethoscope, but should we also buy a very cheap ophthalmoscope, and might that lead to more ophthalmologists? And I wondered if you'd had done anything towards that.
Yeah, I mean, obviously the medical students market for this is important. What we're doing is a social enterprise in the sense that we're devices being sold to rich people in rich countries at a certain price, around £50, and then that cross-subsidises distribution to low-resource countries. And so, yeah, we do need to think about marketing. We recently employed a manager to actually do all that kind of that kind of stuff. And the medical student market is clearly something important to aim at. It has been the orthodoxy, hasn't it, to have a stethoscope around your neck as a medical student, but it's not been the orthodoxy as a medical student to own an ophthalmoscope or an otoscope. And I think the reason for that would be, they're a bit big and bulky, and they're relatively expensive. But so I suppose now an arc light, an ophthalmoscope otoscope combination, this thing is not so expensive, and you can have it on your top pocket or like that, and you carry it around, so it's not too much of a big deal anymore. So maybe it will become the orthodoxy in time. It'd be certainly nice to move that way, because no one can ever find an ophthalmoscope on a ward, and if they can, guaranteed it's not working. That goes for the eye clinic as well.
And if we can't buy them on Amazon, where can we buy them? If anyone's
so in the UK, the ArcLight device is sold purely through the St Andrews online shop. It's now getting itself onto a few other different non-Amazon platforms, but essentially just through the St Andrews online shop.
Okay, and what about the semis? Are they available as well?
Yeah, so if you buy an ArcLight, you get a semi. But yeah, so the simulation eyes are available in bags of kind of 25 or 30 for, I think it's like 10 quid or something like that. And yeah, I mean, they're really useful, the semis. The nice thing about them is that the flexibility of them from the point of view of training and assessing, and they say getting people around the table and picking up the eyes, looking at them, having labels on them saying what's actually inside them, and they examine them, they know that's that, and then clearing them all away, go off for a tea break, and then come back and then have a table where you just got numbered semis and a bit of paper, pen and paper, and then again the same group are picking them up now and looking and trying to work out what they're seeing and writing down what they are, and then you can talk about the answers. So I have to admit, it's an incredibly effective and fun and engaging way of training and assessing people in a very short period of time, not just on the kind of back of the eye stuff, but also on the fundal reflex appearances as well, the cataract and retinoblastoma and stuff, which is really quite an important deal now, as I say, in low resource countries, because WHO are probably moving in the next few months to recommending that the eye examination is part of your routine neonatal examination, which it hasn't been until recently, because there hasn't been a device available appropriate for that kind of setting. But now the ArcLight is available, and the evidence base is fine with the device. The evidence base for the fundal reflex examination is okay. It's not the strongest, it's not the best test in the world, not the best screening test, but it's still certainly countries that do it do pick up cataract and retinoblastoma earlier than countries that don't do it. And we've got some nice examples of that in Scandinavia, where some Scandinavian countries do the neonatal eye exam and some don't. And the ones that do, well, the cases do present a few months earlier on average. So moving towards that.
Great. It must be fun to be a medical student in St Andrews, I think. That sounds really nice.
Well, if you're looking at the world as an ophthalmologist, yeah, it's nice. But you're right. I mean, I think the package, what we do for the undergraduates, and of course we've got our postgraduate ScotGem course now, and with the medical students going through there as well. They do take up quite a lot of time and effort. I've got my ScotGem teaching week next week actually with them all, so I've been busy kind of polishing all that up today.
And I was just thinking about the potential overlap actually between the work you're doing, Neil, and Andrew's work in terms of artificial intelligence. And I know if you're looking at using devices in parts of the world where people aren't necessarily trained to a high level, I wondered, Andrew, have you been looking at artificial intelligence to help with look at the images from the ArcLight? Or?
Well, just a little bit. I mean, obviously you can attach the ArcLight to the phone using this little clip, and so you can get nice fundal reflex video and back of the eye video, especially in dilated patients. So we have done a little bit of work with that in the computer science department in St Andrews. It's very strong actually in the AI sphere. And so obviously optic nerve head cupping, we've tried a wee go at that, the montaging of video into a wider single image to overcome the innate narrow field optics of direct ophthalmoscopy. But I'm a bit loath to pursue that too aggressively. It's really what we're trying to do is train, equip, empower primary and mid-level workers in low-resource countries to be able to use this to diagnose the kind of big causes of blindness in the world and refer patients on more promptly to try and get better outcomes. And I think that should really be our main focus. But obviously, the kind of telemedicine side of things and the big data, it does is where the money is, and it's sexy, and you are pulled that way, and so we do have to acknowledge that and do stuff in that area. So, and that's just the reality of being in this kind of academic world, whereby sometimes it's the sexy things that get the money rather than necessarily the kind of the more obvious things about basically putting one of these in the hand of a ophthalmic clinical officer in Malawi for them to do their job better.
Great. Well, thank you very much. I don't think we have any other questions from the attendees, and you've answered all of my questions. So I think we should probably draw the session to a close. So thank you very much, Neil, Andrew, and Manjit. Really, really nice talks, and incredible to see the work that's going on across Scotland and globally, the global impact that work has. So I will finalise this part of the session. I'll hand back to Professor Sanders.
Thank you for an absolutely fascinating last session. So wonderful to see such pioneering work coming out of Scotland with huge global reach. I hope in meetings to come, we will see all the 3 pieces of work evolve and the results. So I shall end with particular thanks to Oliver Tomlins, who has been overseeing today. He's been dealing with over 20 speakers and chairs, and there was a total of over 90 registrations with people coming on and off. So thank you so much, Oliver. All the lectures are pre-recorded if you want to hear them, and all the internet, all the websites and all the research opportunities are on these websites. So please speak to Oliver for any contacts. Again, my particular thanks to the 3 chairs, Bal Dillon, David Lockington, and Andrew, for carefully theming and planning their sessions and approaching the speakers for absolutely super sessions. It's been a really good day. Naturally, thanks to the Chief Scientist Office for supporting this day. There is a little feedback survey, and we'd be very grateful if you fill that in, because it gives the CSO feedback and allows us to continue year upon year. And, you know, we like your feedback because we like to improve, and please suggest further topics that you can think of. So nothing left to say other than thank you very much for a very interesting and interactive day and for the effort of attending and contributing. Thank you.
Thank you.